And part of that is because of its breadth and its ability to support the NHS effectively in getting people out of hospital quicker. And actually, I think we'd probably all agree, create a better offer in the community anyway. This is where we want everybody to be. We don't want them to be stuck in hospital where we can't give all those additional pieces. So we'll describe how that's worked. And then what we do is then have a Q&A after the presentations are done. But please do use the hands up if you have questions. And the other bit that people find useful is you can also just pop a comment or a question in the chat, and between Chloe and myself in the background, we can help answer those as we go along if that's needed. And I just wanted a quick call out to Alex Renick, who has joined us today. Alex is from the Department of Health and Social Care, and we are delighted that she's come to work with us for 2 weeks on a sort of semi-secondment and looking at what we do. Really useful to get that provider perspective back into the Department of Health. So thank you for that, and welcome, Alex.
Thank you. Very, very happy to be here.
Good, great. And then I think that's just about all for me, unless I've left something behind. And I think I'm handing over to Rosie, if that's right.
Yeah, I'm just trying to share my screen, so just let me know when it's come up. Can I just check as well? I think what we're going to try and do, as long as everybody's all right, is probably record the session, just because we always have people that register and haven't. So as long as everybody's all right, feel free to turn your cameras off if you don't want to be recorded, or just comment quietly in the background through the chat and things, but just to let people know. But I'm Rosie, and I work as part of the new Models of Care team at Home Group. Can I just check you can see the slides and things? They are up now. Yeah,
we
perfect.
can. Yeah.
Yeah, brilliant. So I work as part of the Model of Care team at Home Group. And as Rachel mentioned, I'm going to tell you a little bit about our Cntw hospital discharge service. So it was a pilot scheme that was developed in partnership with the Trust. And it was all kind of primarily aimed at reducing pressures on inpatient wards on kind of both sides of the pathway. So preventing avoidable admissions, but also helping improve patient flow for those who do end up in hospital as well. So I'll start with a little bit of background and explain a bit about how it got started. So my role at Home Group is all really about engagement, and I work with different health and local authority commissioners and stakeholders to really try and understand an area. So I spend a lot of my time learning about what is going on in different areas, what existing services there are, and also trying to understand any pressure points on systems and any gaps in provision. So that's what I do externally, but I also do a very similar thing internally as well. So I spend a lot of my time liaising with our operations teams up and down the country to find what services we already do and what's working well and where things can improve. And then I try and use that to share best practice, both internally and externally. And that's really how the hospital discharge and crisis service got started, how this Cntw service got started. So a hospital discharge and crisis support isn't something that's new for us. We've had a long running service within Durham and Darlington. And when I joined Home Group a couple of years ago, it was one of the first schemes that I found out about, and it really just seemed to make sense. And the reason for that is, you know, as I'm sure you already know, but we've been, as an organisation, we've been delivering care and support services for a number of years alongside our social housing offer. And what this service does is it lets us kind of bring both of those elements together. So it really lets us play to our strengths and add something extra to that support model because of our housing offer. So the idea of the service, I'll move to the next slide if I can, is that for the hospital discharge service, we've got support coordinators that work on the mental health wards, whether that be acute or rehab wards, and they work alongside the clinical team. But we provide any housing or social support that's required, either from the point of admission or as soon as it's medically appropriate for us to do so. So we try and address or resolve any potential housing barriers to discharge and support with any other potential needs relating to things like access and benefits, managing a tenancy, managing their finances, developing independent living skills, all of those things. And then we then stay with that person following the discharge from hospital into the community. So we provide short-term support in the community to then make sure that that person's able to cope with the transition from the ward into the community as well. So the key aim of the service is it's all really about making sure people have access to safe and secure housing. That's kind of the #1 priority. And trying to help reduce inpatient stay and delayed discharge that relate to housing or housing barriers, and also reduce any avoidable readmissions that might result from people not being able to cope with that step down into the community. The crisis service is quite similar, but it's the other end of the pathway. So instead of supporting people who are already in hospital, we work alongside the crisis and PLT services to support people who contact crisis but whose escalation in mental health symptoms comes as a result of a housing or social issue. And then what we do is we provide an outreach support service into the community, trying to help resolve some of those issues, but with the aim of helping people be able to remain in the community without the need for further crisis support or secondary care admission. So the Durham and Darlington service, as well as the more recent Teesside service, have been going for quite a while, and they've had some really amazing outcomes and really evidenced all of the things that, you know, I said were the key aims and the things that we wanted to achieve. But there's been some kind of key factors to those success, or to that success. So some of the key elements were the fact that we had a good relationship with the trust. Both of those services, or all of those services, were developed in real partnership. So we really understood what the pressures were on the inpatient and the crisis services. And we understood that a lot of those customers that were presenting to those teams did have a housing or social support need. So there was an element that we could actually address and kind of use our experience to help resolve. One of the other key factors was our experience in delivering housing related and social support, not just within this type of service, but also within a range of our care and support services, including just within our general needs properties with our social housing customers. So we've got really established relationships across the region with things like social care services, other housing associations as well, health services, voluntary sector organisations, as well as the fact that we obviously really understand the housing processes in those areas because we're a part of it. So we understand how to navigate the system and get the best outcomes for the individuals. Another key factor was our support infrastructure. So again, within the North East, we've got a lot of care and support services. So we've got things like existing management structure in place and experienced support teams. And we've also got a significant property offer as well, so a lot of property infrastructure. So we've got a lot of stock within the region, which gives us a lot more options when it comes to individuals who fall into that kind of hard to house box, or those more difficult customers that might present with complex support needs, forensic history, arrears, all of those type of things. It lets us kind of work a little bit more creatively and sometimes think about how we can include our stock to help resolve some of those issues. So it was this best practice that I then shared with Cntw to see if there was the same if they had the same need, because a lot of the key factors that made this service a success in Durham and Teesside actually were also applicable across the Cntw footprint. So after initial discussion with the trust, it was agreed that there was a need, and there was also some short-term potential funding that could be used to support a 12-month pilot scheme. But they didn't want an off-the-shelf kind of like-for-like service, so there were a couple of factors that they wanted to include to make sure that the scheme was adapted to best support their region. So firstly, one of the things we looked at was that it didn't just cover one locality. So Cntw has quite a large footprint all the way from Northumberland and kind of a lot of the North East and then Cumbria as well. And one of the things they didn't want is just to have a service in one area, because it potentially created a bit of inequality where essentially if somebody presents to hospital, they might be moved out of area depending on where the available bed was. So they wanted teams to be able to follow that customer through their journey and be able to provide community support and move on support. So they were really keen to kind of set up the service across the 4 key localities. So the way we did that was we had 4 separate teams. We had a team for the north, which was Northumberland and North Tyneside. We had a central team covering Newcastle and Gateshead, a south team which covered Sunderland and South Tyneside, and then a North Cumbrian team as well. And for all those separate teams operated individually, there was some shared management infrastructure as well that brought those teams together. And during the implementation process, those teams worked really, really closely together, both to ensure consistency of delivery, but also to build some of those connections between the teams so that it was a bit more seamless when we set that up. And that has worked really, really well so far. So The way that works in practice is that if, for example, somebody presents on a ward in Cumbria, but they're actually from Gateshead, the Cumbrian team would pick that person up, carry out the assessment, provide any ward-based support, but they would liaise really early on with the central team to understand or to let them get involved with any sourcing of housing in their local area that was needed. And then following discharge, the Cumbrian team would hand over to the central team for any community-based support that's required. The second need for the trust was all around flexibility. So this service was quite new to CNTW, and there was questions raised around where the demand would come from. So they weren't sure whether there'd be more demand in hospital discharge or crisis support, and what specific wards had greater numbers of customers that would present with housing need. So because of this, the model we developed allowed for more regular review of activity, with our team being able to shift around and move between different aspects of the service as needed, so that we could meet that demand and just provide the greatest value to the locality. So to do this, we've been collecting data regarding where the referrals have come from, and we regularly feed this back at contract review meetings. So this is one of the ways this has been shown is with regards to the crisis services. So initially, we only had a crisis support element working in Cumbria. The other 3 localities had us all based on the ward. But actually, we found that there was quite a big need within crisis. So since then, we've adapted it, and we've got some people working across both. So we've just been able to move the team around to suit and again create the greatest value for the service. It was also really important for us to understand local structures and adjust our approach to fit within local teams. So, for example, within the north, there was already a discharge facilitation team in place on the ward, and there was questions raised about how we would fit in with that. And obviously, we wanted to avoid any duplication of efforts and things like that. So prior to the service going live, we arranged meetings with the team so we could learn more about their roles and responsibilities and share some of the skills and experience that we could offer. We then, since starting the service, we've worked in partnership with the team, so really worked hard to avoid any duplication of efforts and almost created one kind of more enhanced discharge facilitation team rather than working as 2 separate services that don't talk, and avoiding any confusion on the wards about who people should be referred to. So it went live at the beginning of April and it's absolutely flying. So I will hand over to Shadia to talk you through a bit more of how it works at an operational level.
Thanks, Rosie. Yeah, I'm Shadia. I'm the operations manager. So, and I oversee the implementation of this service from an ops level. So took responsibility for that integration element, but also everything from the recruitment of the management and staff within the 4 localities, and then just bringing to life and bringing to reality the service that Rosie has just talked about. So as Rosie said, we're based on the mental health wards and within the crisis teams with the aim of preventing admissions and reducing time spent on the wards. And very much have delivered this service as housing specialists and specialising in housing related support, experts in our fields, which means that we're able to navigate the complex housing sector. The type of support that we deliver is broken down into 3 main groups: advocacy and signposting, practical support and emotional support. And what we do every day changes on a daily basis. So it can be anything from signposting and supporting with paperwork, access to housing stock, tenancy management, finances, benefit claims, increasing social engagement, reducing social isolation, access to employment, and even access to specialist accredited qualifications through our own home achievement programme. But what is most important is that the support that we offer is tailored to each individual, so every day can look very different one day to the next. We have, in that implementation, we have faced a few challenges that we've shown here, mainly with teams on the wards and in crisis provision not really understanding what we're able to do and when we'd be able to do it. So we spent a lot of time getting to know the teams and really understanding the challenges that they face and the backlog that they had. We are still working towards getting access to RIO, which will help us from a risk sharing perspective. But one of the biggest challenges that we've faced has been around ongoing need. So I did see there was a little question popped up in the chat before. A lot of the service users that we've been supporting in the community have got long-term support needs, but there's been a lack of appropriate or other community provision, which has made it a little bit difficult to facilitate move on. So what are the solutions? So one piece of the puzzle has been our service called STEP, and STEP stands for Sustaining Tenancies and Enabling People. The STEP model focuses on providing a holistic support to customers, which is based very much on individual need. It can include housing, access to furniture, intensive housing management, wraparound support packages, or any combination of these four. The service focuses on individualised packages of care that can be adapted as a person's needs change. And the nature of the service allows for us to increase or decrease support hours really quickly as required. When we talk about housing, though, it's not just about housing. It's about the standard of housing, and quite simply, it's about would I live here? It's about more than bricks and mortar. And as a leading housing provider, we use our expertise and experience to support customers to access the right homes for them. Why is furniture important? So I wanted to talk a little bit about a social investment study that I've been involved with that was carried out last year in 2021 that found that 42% of tenants experienced improved mental health due to having furniture provided by the landlord. On average, tenants spend £2,000 a year more on food if they don't have a fridge, around £1,000 a year more at the laundrette if they haven't got a washing machine. 30% of tenants in that social investment study that we were involved in felt less isolated because they had furniture and they could invite people to their home. And a massive 65% of tenants said that they felt proud to live somewhere that they could call home. So furniture is really important. What is intensive housing management and what does that mean? It basically is anything that will ensure safety and security of the building and tenure. It can include anything from assistive technology to face-to-face help with benefits, applications, and even attending appeals. And flexible wraparound support packages is exactly what it says on the tin. It's about delivering what each individual needs at that time in order for them to live well, and it can change day to day. So what does that look like in real life? I wanted to just share a little bit of a video about one of our customers called Joan. Hopefully this will play.
What do you think about it?
Yeah.
To hear it when it come on.
I didn't hear it, no. I'm holding my breath though.
Good example of where we've been able to discharge a customer and save the NHS money is Joan. Joan was detained under the Mental Health Act for approximately 3 years before a referral came to us. The last year of her time in hospital, she was informal. The struggles that they were facing wasn't around her mental health, it was around accessing suitable accommodation. So she was literally on the wards because she had nowhere to live, not because she was mentally unwell. We got the referral for Joan, and within 6 days, Joan had moved into one of our properties. She moved in initially with 2-to-1 support because no one really understood how that would look for Joan. But very quickly, and I'm talking weeks, we reduced Joan's support from 2-to-1 to 1-to-1. We then reduced it again to not 24-hour support. Now, if even the cost of the 2-to-1 24-hour staffing is significantly less than the average stay in hospital, over the period of Joan's tenancy, we've saved the NHS a significant amount of money. But more importantly, Joan's not been in hospital, and she's thriving, she's gardening, she's going shopping and doing her own medication. It's perfect.
And that picture there is Joan, who loves Princess Diana. She volunteers at the garden centre and she's living a fantastic independent life. And she has had, within her time with us, she did have a period of significant ill health and a really traumatic experience, which meant that her support needs did increase again. But the very nature of the STEP service means that we've been able to fluctuate the support to meet exactly what Joan needed at the right time. The next thing that's been really important to the success of the service has been essential to the success of the service that Rosie touched on earlier has been integration with existing hospital teams. And one of the teams that we discussed or we talked about at the initial setup of this service was the Transitional Discharge team that exists as part of the North team. And Mark has really kindly agreed to join us. Mark Bunting is the clinical lead from the Transitional Discharge team based in the North in Morpeth. Hi, Mark.
Good morning, everybody.
Mark's going to talk a little bit about how the service has linked, how our service has linked in with his team, and the benefit, hopefully, that has brought.
First of all, I want to apologise. I was hoping to have some information and lovely facts and figures for you, but they haven't come through to me, so I'm just going to have to wing it a little bit with you. Transitional Discharge team was set up about 12 months ago within the Northumberland and North Tyneside area CBU of Cntw, and we were predominantly asked to look at bed blockage. We had issues on certain wards within the hospital that patients were discharge ready, but for whatever reason they weren't being discharged from hospital, and it mainly came down to housing, benefits, or some financial issue that needed resolving. So we were set up last October. We've barely been going 12 months, and in the early days we winged it because we really didn't have a clue about housing. We didn't have a clue about benefits. So basically a lot of it was guesswork for us. And then came almost Christmas for us in the April of this year when home groups started. My team is very small. There's myself, I've got another band 6, a band 4 and a band 3. And at the minute we're dealing with over 50 clients, and that's just on the St George's Park site. Come April, as I say, it was like Christmas for us because these experts arrived, and I'm not saying that flippantly or undermining it at all. They were exactly what we needed because home group know housing back to front. And since April, we've discharged probably a dozen clients that would still be in hospital now, not just because of housing, but because of that complex needs. And I think this is where we have worked so fantastically well with home group. Initially, we were all a bit nervous because we were thinking they're coming to take our jobs. Basically, they're coming to do what we do. So we got very nervous and very twitchy, but that wasn't the case at all. But what we tried to do in the beginning was we are one team. Home group may be a completely separate entity and a completely separate company, but we are one team. We've got to work together for the best benefits of the clients on our wards, and that's what we've done. The staff that have come to work with us were very open. They listened to what we had to say. When there's issues, we sit down and talk about it. We meet every week and we talk about the clients on our case group. There's very open communication between the leadership of both the teams. Vicky up here in the north and I meet regularly, and we talk about not just what's going on with the clients, but what's going on with the staff, because that's important as well, and that's what's worked so well. The benefit that we've had more than anything else, as I said in the beginning, is that expertise when it comes to housing. We've housed some very, very complex, high-risk patients in home group facilities, but we've also housed them in private facilities with home group step-up support, which we would never have been able to do, or we would have struggled to do. And I know we get fantastic support from the social workers that we have worked within the team and closely with us as well, but it's a challenge for them as well. Whereas we've now got a system that we're trying to replicate now within the central aspect of Cntw and the south, and they're starting to put teams like ours together in those areas to work hand in hand with home group. We've had an interesting first 6-8 months. It's growing. It's happening. Things are happening faster. In the beginning, things were maybe a little slow, but that was us getting to know each other and knowing who was the expert in what. But now we find that we turn around things very, very quickly. And the positive thing about it is access to housing. Home Group have been brilliant with us because they know the ins and outs of systems that we didn't have a clue about. And we have the expertise with the mental health. So that's what makes it work so well. We both use each other's expertise, and long may it continue. Hopefully the teams will expand, and hopefully my team will expand anyway, and we'll just take things forward from here. But it's remarkable the amount of complex individuals we've rehoused in the last 6 months that we would never have done, and these patients would still be in hospital, and they would still be costing vast amounts of money to keep them in hospital. And although we don't like acknowledging that, you know, at the end of the day, it's a money thing, and we can't get away from that. But it's also about ensuring these clients aren't coming back into hospital. And off the top of my head, I can't think of one patient that we've discharged in combination with Home Group that has had to be readmitted because of social situation, because of where they're living. And that was a massive thing for our clients. The readmission rate for housing reasons, benefits reasons, as Abby was saying about furniture, simple things, patients not having carpets down, it doesn't happen anymore. We get all that sorted. And as I say, I can't think of one readmission we've had since we've worked hand in hand together, and we've had some real complex cases.
That's amazing. Thank you, Mark. And you'll be pleased to know I am going to talk about Sean's case in a little while. So it's one that hopefully will make you smile. So, but thank you. I really appreciate your time.
Yeah, thanks, Mark. Before Shadia goes into some of the more important individual case studies, I just want to share some of the other details about how the service has been going. So, as we mentioned, it's been live since April, so we're almost at the end of Q2. I know Shadia talked about some of the challenges we've had and how we're working to make improvements. So I just thought I'd talk through some of the achievements and then some of the stats and things as well. So firstly, in the last kind of 5.5 months, the 4 teams have integrated really, really well with the existing ward-based and crisis PLT services and things. They've been part of report out meetings, MDTs, we've held training sessions, drop-ins, making sure that all the people that we work with really understand who we are, what we're there to do, how we can best provide support, and making sure that we've got kind of all the systems and processes in place to make all of that as seamless as possible. It did take some doing early days, particularly where there was concerns about getting on report outs and hearing things we maybe shouldn't, but it has been that partnership work, and that's really kind of helped us overcome some of that. So what that's meant is that we've had quite a steady stream of referrals. So there was very little thumb twitching or thumb twiddling at the beginning of the service setup and implementation. We got quite a lot of referrals early days, and that's continued quite steadily for the nearly 6 months that the service has been live. The other thing that's been going really well is that flexible approach that we promised at the beginning. So we've adjusted in all 4 of the teams. There's been some adjustments made to make sure that we've got the resource and the staff in the right places where there is the areas of highest demand, whether that be on acute wards, rehab wards, or within the crisis team. And what that means is that no 2 services or no 2 locality services look exactly the same, but they're all very much tailored to the needs of that area. So that's been really evident in crisis, as I mentioned before. So we only started on crisis in Cumbria in the first quarter, and then in Q2 we're everywhere across that, and we're across wards that we weren't previously. And then there's been other wards where we had quite a lot of staff present, where we've taken people out to reallocate somewhere else because we haven't had as many referrals as was anticipated. So that's continually monitored and just making sure again that we get the best value for Cntw. Other things, during the setup of the contract, we brought all of our teams together, as I mentioned, to try and make sure that we could deliver consistently across each of the areas and share best practice. But what that did is it really helped create links between the teams. So everybody knew each other before we even had received our first referral. And that's really helped the teams form the connections they needed to effectively manage the out-of-area referrals and handovers. So that process is completely seamless now, and those teams really do lean on each other, share best practice. If there's any problems, anybody's got any queries, kind of they do, you know, link in with each other and use each other's experience and expertise to help find the best outcome for customers. I'll talk a little bit more on the next slide, and Shadi will go through a couple of case studies, but there's been some really, really amazing outcomes for customers, and you know, that is our primary focus. That's what we do. That's, you know, that's what we value as an organisation. It's about helping those vulnerable people to live as independently as possible within the community, and being able to access them on a ward just means that we can get to them quicker to help set things up so that it's not a problem when they're discharged. And that we've got so many case studies and individual stories that really evidence that we are delivering in that aspect. And for us, that's kind of one of the most important aspects. And then lastly, the other evidence of achievement has been the feedback that we've got from the team. So people like Mark, where we've been working alongside them, it's all been very, very positive, especially when some of them were a little bit hesitant at first, and I can completely understand that. But we, you know, we're pretty persistent. We win people round at the end, I think, even if there is a few concerns. But one of our key objectives from the service was to take some of that load off the clinical teams so that we could resolve the housing issues and they can get back to what they do best, that kind of therapeutic management and, you know, the real kind of mental health treatment and things. And we just stick to what we do best, that housing and social support. And all of the feedback we've got, all of the comments we've got, and I think there's a comment on the side there, really evidences that that's what we've been doing. People kind of are very quick to say this is, you know, an invaluable part of our kind of core offer now, and I don't know how we did it without this, because it really does. It lets them kind of do their clinical things. And when you add that up, it's very difficult. We try to find a way to measure that, because obviously that is time given back, and there is a return on investment, like a cost saving generated for that as well, but it's quite difficult to prove, I suppose. But we look at kind of how many hours that it takes us to support somebody. But when you look at somebody who, before we were there, so a nurse having to previously resolve a housing issue, it might take them 3 times as long because they didn't have the connections, they didn't understand the process as well, they didn't have access to property and all of those things that we can bring to it as well. So it's not just the hours we're delivering that we're giving back to the clinical teams, it's probably excess of that. So in terms of numbers, the first quarter, and if anybody is interested in Q2, I'll have it at the end of this month, so I'm more than happy to share because it is going really, really well. I did peek at it. But the first quarter, we had 170 referrals into the hospital discharge service. And by the end of that quarter, we'd managed to support 77 of those customers back in the community, and there was only 1 readmission. So we're almost now at the end of quarter 2. And so far this quarter, we've had 140 referrals, which seems slightly less, but that's due to us having more presence in the crisis services as well. So we've had a significant increase in that sense. One of the things that we were really keen to evaluate, and again, we're really aware of the fact that this is still a pilot, you know, there's a lot of pressure on NHS to generate efficiencies. So we really needed to look at, are we doing what we think we're doing and what we want to try and achieve, which is reducing that average length of inpatient stay. So we carried out we're carrying out an ongoing study looking at how long people are in hospital that are referred to us. So it's just that client group that essentially have a housing need. And what we did is we looked at everybody who was referred to us but was admitted to the ward prior to our service going live, and then after the service went live in April. And from all of the data gathered in quarter 1, we had 33 patients or service users at that point that were discharged in the community who had been admitted to ward prior to the service going live, and their average duration of inpatient stay was 133 days. Of those who were admitted after April, the average duration of inpatient stay was 34, so it was massively less. And this outcome wasn't from one locality. We were getting the same outcomes in all 4 areas, which I think was really, really key. And again, it's the same outcomes that we get in Durham and Darlington and Teesside as well. So it all kind of backs up, and obviously we've got more data to support that now. But when we look at that in terms of savings, so it's an average reduction of 99 days inpatient stay per person. which when you look at what the average bed cost tonight is, and we got this from the Trust, it's a saving of over £47,000 a service user. And for that first quarter, it was 1.8 million in total, which, you know, I'll not tell you the value of the service, but it's significantly more than they've paid for the service for the whole year, that we've generated savings in the first quarter, potentially. And that we did intentionally exclude 6 people from that study as well. So there were 6 service users within that period who had been on the ward significantly longer than anybody else, over 300 days, because they had quite complex housing needs, and we didn't want that to skew the results, so we took them out. However, at the end of quarter 1, all 6 had been successfully discharged in the community and were thriving. We're doing really, really well. So we've got separate case studies for those that were a little bit more complex as well. With regards to the crisis service, so in quarter 1, we had 64 referrals. As I mentioned, that was because we were already providing crisis support in Cumbria. And since then, we've adapted this to cover all 4 areas. So this quarter, we've got, I think, in excess of 220 crisis referrals in a 3-month period. So again, they're coming in thick and fast. And at the end of quarter 1, we had 20 customers who were discharged from the service into the community. I'm saying into the community, they were already in the community, but discharged from the service, and only 1 of which recontacted crisis and needed secondary care support. I couldn't tell you the exact figure of how many of the 220 have been discharged, but I have checked, and we haven't had any additional people recontact crisis or readmissions to hospital from that aspect of the service. So actually the vast amount of people we're supporting within the crisis service are remaining in the community and not needing further secondary care support. I'll hand over to Shadia, who will be able to give you some more patient-specific outcomes.
Yeah, I get the best bit of talking about the outcomes for individuals and the case studies. And the one that I mentioned to Mark before is one that I know means a lot to you, Mark. So I wanted to introduce Sean. Sean was admitted to hospital in July of 2012. He presented as delusional, thought disordered, physically and verbally hostile towards others, and he'd stopped taking his medication, and he was admitted directly to the psychiatric intensive care unit. Sean remained an inpatient from 2012 until he was transferred to the Kinnersley ward for a period of rehabilitation in 2015. At that point, Sean's admission was extended due to a lack of progress in helping him to adapt to supported living. I know there was multiple attempts or multiple discharge plans throughout the years, and 2 attempts to actually discharge Sean, but both failed. And in April 2022, Sean was referred into our service. He was reluctant at first, and initial engagement was tough. He would miss his planned support sessions, but when the team spoke to him to find out why, one of the reasons was that he had his routine and he used to like to get the bus at 9 AM. So we rescheduled his support sessions for 8 AM and Sean started to engage. He was supported to apply for multiple benefits such as housing benefit, PIP, ESA, and Sean actually said he had no idea that he could receive different benefits all at once. And after a few sessions with us, he was offered a property in Leamington in Newcastle. And Sean was reluctant at first, but after viewing the property, he became eager to move. He signed his tenancy agreement and couldn't wait to move in. He'd even arranged to meet with a member of the STEP team every day to check in and just make sure that everything was going well. Sean was discharged on the 25th of July 2022, and he's doing great. He engages every day with the STEP team every evening, and his independent living skills are just coming on leaps and bounds. He engages well on phone calls, he's always polite, he takes his medication, and he meets with the CTT regularly. Sean even unpacked all of his moving boxes independently, which was something that the ward staff said he would never do. He's worked hard with rehabilitation, and we couldn't be more delighted with how well he's coped with the transition from hospital to community. And we're all just over the moon that after 10-year admission, Sean has somewhere that he can call home. Sean is probably the most impactful referral that we've worked with, but he is one of many. And Mark, I don't know if you want to add anything about Sean, because I know you had spent a lot of time working with Sean.
We did, and this gentleman is one of many that the reason for our team really was put together in the first place. That we had a lot of clients, and we still have some clients who they have significant challenges when it comes to being discharged from hospital. Now, people will automatically think, oh, well, it's violence, it's aggression, it's drugs. No, sometimes it's just that social insecurity and needing that level of intense support, but not somebody that needs 24-hour care. And that's where we struggle sometimes, I think, within health, because if you don't fit into a little box, then we don't provide that service for you. So you can either have independent living with people going in once in a while, or you can have supported 24-hour care. And this gentleman didn't want that, but we found that perfect mix of independence and support, and doing it through home group in one of their properties just teed it off. But knowing that the staff are there to support his tenancy, to make sure his bills is paid, to make sure his benefits is coming in, along with the practical stuff that he is shopping, that he is eating, that he is taking care of himself, is just what's doing him the absolute power of good. And he is one that board staff, a lot of people have been, I suppose, rightly frustrated over the years that he's had opportunities and we've just not got it right. And it just how it happens this time that we got it right, I suppose, with home group.
And he has his home, so yeah, definite win. Another case study is Andrew. Andrew has a diagnosis of psychosis and query depression, and he was admitted to hospital just last year in November 2021. His mental decline was due to the loss of his mother and stepmother, and he's also experienced a breakdown in his relationship, and Andrew hasn't actually seen his daughter in over 4 years. Due to Andrew's decline in his mental health, he fell behind on his service charges, which led to his housing benefit being stopped, and eventually he was bankrupt and eventually homeless. Andrew was referred to home group on the 7th of April, and we've supported him with his bankruptcy application, obtained identification, set up a bank account, and changed his benefits. That's when we started the property search, working with his social worker and CPN to develop a real person-centred support package to enable him to leave hospital. He was discharged from hospital into his own tenancy in June of this year, and he'll continue to receive ongoing support from the STEP team for as long as it's required. He started to rebuild his contact with his ex-partner and is hoping to be able to redevelop a relationship with his daughter in time. Another case study is Angus, who is 42-year-old. He has a diagnosis of EUPD and PTSD. Angus has made 4 attempts to take his own life previously, but the most recent was in March of 2022. He's been self-harming, and he was admitted to hospital following consuming a large amount of alcohol and a significant episode of self-harm. He has also historically used cocaine, but as well as his mental health, he also struggles with his physical health. He's got COPD, type 2 diabetes, and some mobility issues. And later on this year, he is booked in to have his leg amputated. Angus advised that he had lived previously with a housing association in Workington, but the neighbours became fixated on him and were making allegations against him, which led to him receiving a warning letter from the housing association, and he was actually arrested for assault, although there was no action taken. The neighbours had threatened to burn down his bungalow, and he got to the point where he was too frightened to leave the house. He wouldn't go outside at all. He felt isolated and he was unable to cope. He was referred to home group in July of 2022, and he engaged really, really well. We arranged for him to view a property, a ground floor flat with a wet room in Maryport, but he was worried, understandably, because he had a dog and he wanted to take the dog with him. He didn't want to be separated. So, of course, we approved the dog to move with him. Angus is taking small steps to building his independent living skills. There's a small support office close to where his flat is, and he'll go and visit the support office for a chat or a cup of coffee, or just use the dartboard. He started walking his dog around the block, and he's now even started going to the supermarket with his support worker. Angus is registered with his local GP and started taking cookery lessons. We're now discussing with him how he'll manage once he's had his upcoming surgery, and we're starting to explore long-term housing options for the future with him. And there's so many more, as Mark has kind of said, and how, as Rosie has said, there's so many more people that the data represents, and the changes that we've been able to make are genuinely life-changing, and we just want to continue doing that. So what's next? At the moment, as Rosie said, we're 6 months into a 12-month pilot. We're working now with the trust to assess the impact, and we're looking at how we can get long-term funding to be able to continue offering this service. We're also looking at other regions, and I know I had a quick look, there's been a lot of questions in the chat about other areas where we work in. So we're looking at other regions where we could work in partnership with trusts to deliver a similar service, particularly those areas where we already have existing infrastructure from which we'd be able to grow. So watch this space. And it's now my job to ask if there's any questions. Silence. Over to you then, Rosie. Oh, there's a couple of hands
I think
up.
there are lots of questions on the chat, if you can answer some of them.
There are, yes. We'll go through them now, if that's okay. So I'll shout them out. Okay, so first one we have is, oh, let me scroll down because there's a lot on there. We'll go with, I think it was Nigel. Bear with me. Yeah, Nigel. And Nigel has asked, how do you work with local authority homeless teams for those who are at no fixed abode?
Can I answer that one?
Yeah, if you don't mind, thank you.
We, as a registered social landlord, we already have existing relationships with those homelessness teams. So although it's kind of difficult to articulate, the majority of our referrals do come across areas, and they do come from within the ward teams. But sometimes we will kind of work across areas, and we'll get those referrals coming through those homelessness teams. And we do the same as we would do with every other patient, which is assess the housing need and either support them to bid for a property through the provision that there already is there, so through choice-based lettings or whatever the system is that's being used, or where appropriate, we would look to access our housing stock as well. So we use whatever is out there for us.
I hope that answers your question, Nigel. Next one, we'll go to Gillian's question, which I think Mark's kind of helped us answer there, but I'll still read it out because, yeah, there's some similar ones. How does it work once transitional discharge team discharged care back to the local area teams? Does home care continue to be involved, and what is the clinical support in place going forward?
Yeah, Mark has very kindly answered that on behalf of the transitional discharge team in the north, but it is very person-centred, so it is very much based on the individual. We will work with the clinical teams and with the care teams whilst the patient is on the ward to assess what their ongoing needs will be. So that might mean engagement with the community treatment teams, it might mean engagement with nursing teams, with GP practices, with other specialist teams that are out there as well, whether it's around drug and alcohol, physical or mental health needs. We'll continue with that engagement, and that sometimes more often than not requires engagement with the social care teams. So we work very closely with the social care teams as well to make sure that any packages of social care is approved and that we can continue with that. Sometimes that means, we will work with that patient, as Mark has said, for a period of 6 to 8 weeks once they're discharged from hospital, and then we will hand them over to the relevant experts for whatever that person needs. Sometimes their ongoing housing and social needs are greater, which is where the STEP service comes in. So STEP comes in and we'll negotiate a wraparound package of support, which can include things like attending appointments, supporting to attend appointments, signposting to appropriate services. So it's very difficult to pigeonhole it because it is absolutely person-centred, but we continue that support for as long as the person requires.
Fab, thanks, Shadia. Next question. When housing proves difficult to source, would you use your own stock to facilitate the move on? That's from Jamie.
Absolutely.
Nice, quick answer there.
Can I add to that? Because one of the things is, because we get to know the customer better on the wards, we're obviously involved earlier, we can be a bit more positive with risk taking and things like that. You know, if normally we'd get a referral to our housing stock and it would just come through saying forensic history or arson or something like that. Whereas actually, because we know that customer and we work with the team that is all involved in that kind of wraparound care for that individual, we can really build a picture of what the risk is and kind of understand it and understand better whether we can manage it. So actually, that's what lets us kind of be a bit more creative with some of those more complex customers. It's not all about just using our stock either. We do refer into other housing stock and other providers, but there's definitely kind of, that is an added benefit, if you like, of what we can bring because we have that offer.
Thanks, Rosie. Next question from James. Do packages of care need to follow existing local commissioning arrangements or processes, e.g. involvement of local authority, allocation of worker, funding approval, etc., or is attached support funded via housing benefit?
Again, it's very much dependent on that individual person's needs and also their eligibility. So we will, and this is where our expertise and our experience comes in. We do have existing commission supported services. So it's not just about tapping into our general needs stock as well. It's about tapping into our existing supported services and other existing supported services from other providers where that's appropriate, seeking the appropriate funding for that through social services, and finding the right package of housing and support for that individual. But sometimes where that doesn't exist, again, that's where step service comes in, and that may mean access and service through continuous healthcare, through Section 117 aftercare funding, or through social care funding. But it just depends on what that individual person is eligible. Where there is a housing benefit eligibility, then yes, we will utilise that as well.
Thanks, Shadia. We do have some questions from Jackie, who has asked, do you take both secondary and primary care referrals? And what is timeline of maximum support going forward being in the community?
In theory, it's funded through health. So we take the bulk of our referrals do come from crisis and ward-based teams, but it is very much integrated with all of the services. And again, it's, you know, when the key aims are about preventing people going into hospital, if there's somebody who's really at risk, we can work together to see if there is an option there. STEP sits slightly separate to the hospital discharge as well. So the STEP service, we can accept referrals from other avenues. So if somebody's in the community and is involved with primary care or CTT or something like that, actually they can still contact that team. We can see if there's a solution that way. It's just the hospital discharge and crisis support that's funded primarily by Cntw. In terms of the duration of support, I think contract-wise, it's up to 6 months in the community. Now that would be at an extreme case. Most of it is, like Shadia says, it's to 6 to 8 weeks in the community to help somebody manage that transition. Because if somebody needs longer term support, really, we should be trying to see what the next step to access that is. The hospital discharge isn't a long-term community support provision, so it's looking about, do they need the STEP service, or is there other supported living services that are relevant for that individual? It's about finding what the right answer is.
Thank you. Another question from Matt Williams. He wants to know, how long does it take to develop a working relationship with the transitional discharge team?
Mark might be better answering that one.
I know.
When did you like us?
I think that again, I don't want to sound flippant or anything, but from our point of view, it was very, very easy, because I think we welcomed the expertise that Home Group provided, and I think as inpatient services, that's what we've got to do. We can't continue just to protect our own little space and say this is our job and we don't need help. We clearly do need help, and Home Group have provided that with us. But I suppose one thing that I wanted to do when Home Group came in was, as I said when I spoke earlier, was to ensure that there was no division between teams. We are all here for the same job, to do the same thing, for the benefit of the clients that we're working with. And we can't do that if you're sat in an office at a different part of the hospital, or if we don't talk, we don't communicate, we don't have meetings, we don't discuss things. That's what we had to do. So we are one team, different organisations, but we're one team, and that's the only way it works. And I think our relationship with Home Group, probably within the first couple of weeks, was absolutely spot on. And we had that honesty about it. But I think that's, if you're looking at doing something in your own areas, this is what you've got to do. You've got to be honest about it. And there's no point having this almost protectionist attitude that we don't want people coming in criticising, or we don't want people coming in pointing the fingers. We were well aware that we had problems. That's why my team was set up, because there was problems identified. There's no point identifying those problems, then saying we're not going to work with you with it, because it just defeats the purpose, and it stops the clients getting the care and treatment and the community care and treatment that they deserve and that they need. So I'm hoping, and I'm hoping Shadia will back me up, that our team and Home Group were working hand in hand within weeks, and it's just getting better as we talk. And as I said, they're trying to replicate what we've got in the north and North Tyneside here in central and south, and that just proves, because you know we were nervous in the beginning, but you've got to let go of that, and we've got to have one aim and one goal, and I think that's what we do.
Roy, I think there's quite a few questions in the chat about things like funding and the actual model. I'm more than happy to answer that in like follow-up information and send it out after, because I think a lot of people might find that quite useful. If you want to, because I'm just aware that it's literally 11 o'clock.
It is, isn't it?
And there's a couple of people with hands up. Should we let them ask their questions, and then everything we haven't answered, I will happily send responses to in a follow-up email. And if you have more questions, just get in touch as well. We're happy to answer anything.
So we'll just go to Joanne, who's got her hand up, and then, yeah, as Rosie said, we'll answer the questions as part of the follow-up.
Hi there. Just one quick question, because obviously I just wanted to reiterate what Mark and yourselves have been saying, because obviously I have the advantage that I manage the inpatient social work team for the North. So obviously, you know, we're around the table keen players in supporting people for their discharge, timely discharges. But what I was interested in is you're saying that you're sort of moving the model out to south and central areas. And I understand the need for CNTW to have that consistency, but you're working with different local authorities and who might have different commissioning processes. So I was just wondering what sort of work's been undertaken with those local authorities to sort of like support this model and make sure that there's no delays with supporting the discharge for people who might need funded packages of care.
Shadia, do you want to do this?
Yeah.
Or? Yeah.
Yeah, absolutely. Well, there is, from our perspective, and I think there's two sides to it, so I wasn't sure if Mark was going to answer a little bit there, but from our perspective, there is a lot of pre-work going on, Joanne. So we're having advanced conversations with not just the social care teams, but also housing benefit, the social care managers across all of those areas, so Gateshead, Newcastle, and in the south as well, so South Tyneside and Sunderland. So having those pre-conversations, just it's more about explaining what it is that we're looking to do, what we can do and what we can offer, and working out how it then fits with them, because as you say, each local authority works very, very differently. And also we have a different offer in each local authority as well. We have a slightly different provision in each local authority when it comes to pre-commissioned services and what's already existing. So yeah, we're doing that pre-work at the moment to just really inform. And I think that's been, Mark, I think, you know, I know you thoroughly enjoyed our energy when the team first came into the North area, but it's been the communication really that has, as you said, you hit the nail on the head, it's that honesty, but that early communication. And, you know, I said one of the biggest challenges was everybody understanding what it is we could do, and all we could do was talk about it, wasn't it?
I mean, any support that we could offer in terms of how we have all worked together as a local authority with yourself and with Mark, we're more than happy, because I think the model that we have in the North has worked, you know, and like you've highlighted, it's supported lots of complex hospital discharges, you know, that for people that have been timely, reduced the length of stays for some people. But, you know, like you've all highlighted, it's about that working together for all agencies, a real MDT approach. But yeah, any support we can offer, more than happy.
Oh, brilliant. Thank you, Joanne.
I think the benefit, Joanne, as well, is that because the beds in our trust aren't necessarily for a Sunderland patient, or and you can end up anywhere, that we've had a lot of work with services in Sunderland and the central area anyway, and worked with the local authority. So we already have links with local authorities, with housing in Sunderland, with housing in Gateshead, South Tyneside. So we've already developed and built a lot of those relationships anyway, that teams can just take forward when CNTW sort of expands the services, hopefully in the next few months.
Right, so on that last note, I think that answers all the questions for now, but we will go through all the meeting chats and make sure everything was answered, and send you the slides, a recording of the session, and try and answer as many of those questions during the follow-up. And if there is anything that you do need help with, Rosie covers the North and I cover the South. So I've put our contact details in the chat as well, and we'll liaise with Shadi around any of those questions. So thank you so much, everyone, and we'll speak to you soon.
Thank you.
Thank you.
Thank you so much.
Bye now.
Thank you.
Thank you, Shadia and Mark. Yeah, and Rosie and Mark as well. Thank you. I forgot to say that. How rude of me.
It was implied. I'm all right.
Yeah, we didn't do that in the pre-show, did we?
All right. We stopped the recording.
Bye,
Just remember to trim the end, or they always just get us chatting.